bladder leakage, stress incontinence, urge incontinence, surgical options, medical options, and don't forget the pelvic floor physical therapist. We're here today to talk about bladder leakage with my good friend, Dr. Alex Rogers, another badass female urologist. Thanks for joining me, Alex.
Oh, Kelly, such a pleasure. The queen. We love what you're doing. We're like just cheering you on, all the female urologists out there. And I love talking about the leakage.
Dude, it's incredibly common and not talked about.
Yeah, it's in a black box. How do we get it out of that black box?
Is there's too much shame. I think there's more shame to leakage than sexual dysfunction. I don't know. Possibly.
No, agree.
What do you think?
Yeah, no. I think people talk about dry vagina. They talk about hot flashes. They talk about breast care. Now we can Botox our faces without shame, right?
Good point.
Why do no women talk about how many pads they're buying and that they can't make it to the bathroom on time and they don't even know what they have when it comes to leakage, right? They just come in and they're like, I don't know, I leak. And you're like,
right.
Oh.
And it's an entire aisle in the grocery store, which tells you how big of a problem this is.
Yeah, I think there are more adult incontinence products going into landfills now than baby diapers. And
I heard this was years ago. I heard Japan was the first country to sell more adult diapers than baby diapers.
Yeah, and they figured out too, because they're smart, to incinerate their products to reduce landfill pollution.
Interesting.
Yeah.
Wow. So yeah, super big problem. The design of the female body is we're upright. We've got a lot of heavy things sitting on the pelvis. Our urethras are very short. They're small muscles. Babies go through vaginas and then throw the whole anatomy off. Like, it's very common.
Yeah. 40% of women have overactive bladder. A third have stress incontinence. Many have both overactive bladder and stress incontinence to tease out,
which we call mixed incontinence. That's about 30% of them.
Yep. And people don't know about getting better from it beyond buying pads.
When I was in training, I remember being in a lecture of overactive bladder. And just to break it down for people, overactive bladder is like urgency, frequency, getting up at night to pee, may or may not leak with that. That's called urge incontinence. Doing a lecture, and they're like, we don't really know. It could be a nerve issue. It could be a muscle issue. We don't really know. But what we know now is that hormones play a huge role in it. It's like, why was nobody curious why this happens more when we get older? Like, menopause was, in my memory, was never mentioned in residency. Hormones were never talked about in residency. And everybody's like, we just don't know why it happens. And I'm like, statistically, the data, it's way more common in perimenopause and postmenopause.
Mm-hmm. Each decade of life, increased incidence, especially the overactive bladder side. So, yep, I'm going to do the plug as expected. Hormone replacement all day to help mitigate leakage symptoms.
Yep. I love it.
On board.
An interesting thing when I started getting into really getting into hormones and menopause and stuff, and actually I have a subscription to the menopause journal now, and that's the menopause journal is where the equivalency studies for anticholinergics and vaginal estrogen are. And there's not a lot of studies. But the equivalency studies are in menopause journals. And I'm like, dude, urologists are not reading menopause journals.
Correct.
Unless they're weird like us. But how many urologists do you think understand vaginal estrogen as equivalent to anticholinergics for overactive bladder?
Very few.
That's crazy, right?
Yeah, insane. The ones that listen to your podcast, the small subset of female urologists. But yeah, there's such a underuse of estrogen and hormone replacement for bladder symptoms.
Yeah. Let's go through overactive bladder for people, then we'll go through stress incontinence. So overactive bladder with or without leakage, urgency, frequency. It's like an awareness of I know where all the bathrooms are between here and the next big city. You know where all the bathrooms are at Target and the grocery store. You're just very aware. And a lot of people will have leak without warning with overactive bladder, as opposed to stress incontinence, which is you kind of know when you're going to cough, sneeze, laugh, and be on a trampoline. So that's overactive bladder, to break it down. Because I think a lot of women are like, I just leak. They haven't really paid attention to what is the cause of the leak. And the leak without warning, I'm standing in the line at the grocery store ready to check out and I leak. That's much more likely to be overactive bladder.
and impair quality of life. So when I have patients come in and they have that mixed incontinence, overactive bladder symptoms, stress incontinence, or leakage with a high pressure event, in regards to what really tends to be mitigating or more cumbersome for quality of life, it's definitely the overactive bladder because it's unpredictable, right? You can avoid exercise, you can avoid getting on a trampoline, but if you're out and about, right, you may not be able to bathroom map appropriately, and it's obviously devastating when people have like accidents out of their control out in public or even within the home around family members.
Yeah.
But yeah, correct. Women come in and I actually get super excited when I have a patient and she comes in and she's like, I have OAB. And I'm like, how do you know that? That is so exciting. Tell me how you know that.
Right. I love that. That's so good. Yeah, it's super devastating. One of the most common reasons that people end up going into nursing homes is bladder leakage.
Mm-hmm.
The other risk of getting up at night to pee is falling.
Mm-hmm.
Right.
And
so
it's
not
hard
benign
to treat those patients once they're in that environment because there's just such limited mobility, transportation. So, if we can improve people with their leakage at a younger age, I think we would reduce a lot of the risk of nursing home admissions, breaking your hip, getting up at night.
I mean, I'm sure you see this too, but it's like by the time they come in to see me, they are frail. They can hardly stand. They're in diapers. Their skin's breaking down. Like, I'm sure for the non-medical people listening, sorry, it's a little bit dramatic, but it's like it's so bad. The average one, this was a stat I saw. The average woman waits 8 years before going to see somebody for their bladder leakage.
And what's more terrifying is they might not see the right person. And they might be dismissed and say, oh, well, you could try some Kegels, even though they may or may not get an exam to see if they can actually do a proper Kegel. They may or may not be sent to a trained physical therapist. They may or may not be presented with a full host of options because we have a lot of options. They may simply be given a script that's $5 for an anticholinergic that is linked to cognitive risk and say, come back as needed.
Yeah.
Because there are a lot of, even amongst specialists, that see these patients but don't really want to take care of them long term. And it's a very chronic condition.
Yeah, it's absolutely awful. So anticholinergics they've been around the longest. They're dirt cheap at this point. They're actually, I call them dirty drugs. And what I mean by that is they act in multiple different places in your body. And they're for overactive bladder. They do decrease urgency frequency by working on the muscle of the bladder, but they are contraindicated in age greater than 65. It's in the Beers criteria. In all fairness, the Beers criteria also says estrogen, but I think that that's wrong based upon inaccurate WHI data. But if you want to go by like the biggest, most well-known list of things you should avoid to put in your brain after age 65, anticholinergics is a big one. And there's multiple association studies linked with dementia.
And why would you put that in your body long-term starting at age 30?
Right. Yeah.
Like,
it's not age 65,
it's not right? It's kind of ridiculous. Like,
you have to keep taking
let's do it for decades if you're 30. And also beyond just this cognitive noise out there, they're intolerable. Dry mouth, dry eyes, constipation. A lot of OAB patients are baseline constipated. I am in Colorado. Everyone has dry eyes and dry mouth naturally. So we're actually like going against the treatment mechanism of action. And so I haven't prescribed anticholinergics since 2012 when we got a legacy beta agonist because it was safer, and only prescribe anticholinergics in a very short-term period to get through prior authorizations, tier exemptions, things like that. But yeah, I try and keep minimal use of anticholinergics for so many reasons. Low adherence. Personally, I think the beta agonists are anecdotally more efficacious.
Yep. Way less side effects.
Way less side effects.
And for people who don't know, that's Gemtesa and Mirbetriq, the generics being Mirabegron and Virbegron.
Correct.
Yep.
And of note, in theory, Mirabegron went generic last year, but we'll have to see where that lands because there was an unfavorable lawsuit outcome with Astellas, so it may go away. But yeah, so once again, these beta agonists since approval have been access to them, although efficacious and very safe and well tolerated for the most part. Access has been the biggest issue.
They're
We do
expensive.
get they're expensive. We get help from manufacturer coupons, tier exemptions, prior authorizations. Our friends in Canada sometimes can help us.
But there's hoops. It's always the
Hoops.
burden of hoops. If you look at male
Yep.
urology, they've got dirt cheap drugs. Flomax, dirt cheap.
hmm
Viagra, dirt cheap. Like these medications are not dirt cheap.
They're not.
But the beta agonists, they work by helping the bladder hold more.
hmm
So caution if you have trouble emptying, but any good urologist is going to be checking that in their office. And then mirabegron, contraindicated or concerned if you have poorly controlled hypertension. Yeah.
That's fair. Yep.
Okay. Yeah, I do anticholinergics basically to get insurance to move on to the third line therapies.
Correct.
Now, before we talk about third line therapies, they're no longer called third line therapies. There's a new OAB guideline update. Yeah.
Yeah, I like the rebranding. I call it advanced treatment options or advanced therapies. And it's great. So we got a new update to our Urologic Society guidelines in 2024. And I think it was all positive. Number one, it takes away a stepwise situation of, oh, we have to fail 2 meds to even consider something as benign as putting a little needle in your tibial nerve down in the leg to get a positive restorative effect on your bladder, which is non-invasive, to, your specialist should say, these are your options. And with shared decision making, how do we want to proceed? Now, granted, insurance may not follow that same line of
That was what
thinking.
I was going to ask. Are insurances still requiring failure of 2 medications?
Oh, sometimes 3, sometimes 4. I mean,
Pointless.
it's ridiculous. Sometimes PT, right? So they are not always aligned with the latest guidelines and latest treatments that are coming down the pipes. So it's frustrating because, we know what with these patients, when you look at adherence and following them through, half don't come back to their second visit with a specialist, half
Yeah.
to 70% actually. And I think it's because the way we present things, it seems daunting. Like,
Yeah.
gosh, it's just going to be really hard to get relief. And our cure rates are only, I'd argue 20% for dry. So I think it can be very discouraging. So we have to remove the barriers to how we're going to get people better. Better
Yeah.
is always my word.
I mean, to me,
so I think,
and I think the urology clinic, number one, has to care about these women, because if you're like, oh, this is, whatever, not a sexy thing to take care of, or whatever your bias might be against it, it's a lot harder to have a pathway. So I have a clinical pathway of like, have you tried any meds? Crap, you haven't. Okay, well, we got to do something just for your insurance. 100% get pelvic floor physical therapy, 100% get vaginal estrogen. You start all of that now. And I schedule the follow-up before they even leave the office to be like, at that follow-up, if you're not better, we are going to talk about Botox or sacral neuromodulation, because those are actually the success-wise your highest success treatment. But there's plenty of people who get better on pelvic floor physical therapy and vaginal estrogen. And so it's like, rule that out. Now, not everybody has a great pelvic floor PT. In my town now, they're really booked out. But it's like, in my perfect world, you wouldn't make it to a urologist without having done those things. You don't need a surgeon to do the low-hanging fruit for you.
But unfortunately, where healthcare is just so tapped out.
Yep.
At this point, when I'm trying to get patients into my clinic, in my outreach in a new area for me, I moved from California to Colorado. I'm just asking them, screen for, are you bothered by leakage? That is my only question. And then send them to me. I don't need your note. I will take care of it. No tests, no PT, no meds. Because even getting them to ask that simple question, bothered by leakage, that's a challenge.
Isn't that a Medicare well person mandatory question?
It is. So
that'll take care of the 65-year-old and up.
Exactly. Yeah. But I think there's some of us where we realize it's just really hard at the primary care level to add this to the laundry list of care for that patient. And so my world, it depends on your market, right? Every market's different. That gets handed to me. And I think we're very similar, where it's like a workout plan, right? Like I'm like, here's your menu of options with me. I'm gonna draw all over it. I'm gonna highlight. I'm gonna explain what you have. Like this is like our direction. You're gonna get 2 weeks of gem tested samples. Now, only half of people can sample beta agonists, so that's a barrier right there. I'm going to see you back in 2 weeks. You think you have stress incontinence? We're going to do a leak test. You know, I'm going to borrow from Nicole Fleischman out east. Are we treating women or are we testing them? And in my world, I really try and minimize testing where just urine check for blood, standard of care, PVR, make sure there's not some concerning retention. And then just a simple leak test where you come back and you're modest and you're not, you know, being prodded by a lot of instruments that may or may not change our algorithm for care.
Mhm.
And I think it's really, really important that patients know, man, like there's a plan here.
Yep.
And if this med doesn't work, like there's these other things that I've never even heard of. I mean, how many people's heads start spinning when you're like, we could Botox your bladder? And they're like, but I want it in my face, right? Like, I mean, it blows their mind that we can treat them with pacemakers in the buttocks and stimulation down on the leg with multiple forms, right? Like they look at you like, well, why have I never heard of any of this?
I know. Well, I think it ties back to the shame of it all. People are going like, let me tell you about my pacemaker for my bladder. It's not happening. But you know, I always joke, I'm like, yeah, insurance actually pays for Botox in your bladder. You know, that's what's so exciting about it, because it's a decent dose. It's rare to get 100 units in your face, and the bladder standard starts at 100 units. It's a decent dose of Botox to get it to work. But Botox, in my opinion, is a game changer for urge incontinence and overactive bladder. Game changer.
Agreed.
And people are shocked. They're like, I don't know. I'm like, it's been FDA approved since 2013. 2013. No, probably earlier. It was off-label. It was off-label when I was in residency, finished residency in 2012. It was FDA approved right around there. So it's been over 10 years, 15 years.
And that was where it went from neurogenic to indicated for idiopathic. So it really opened up 5 out of 6 OAB patients, right, in theory. But so Botox. So I want to ask you, Kelly. So when you look at the data, like 90% stop doing it by the 4th injection, right? So that's only 2 years of treatment. I think there's something special amongst female urologists. How do we keep them coming back? What are your tricks to make Botox something where patients are like, oh, that was awesome, and I'm in it with you on this treatment, because I'm a big Botox lover as well. So
we actually looked at our data. So we looked at it. I was the highest Botox injector by volume on the west side of Washington State. So a ton of Botox, which means I'm not seeing that many new patients, right? So it means they're coming back. And so I had a very high return rate compared to for nationwide on this. And so they actually came and they're like, what do you do? So we have a dedicated Botox day. So the doctor's not running in between other patients and they're late and the staff doesn't know what they're doing and blah, blah, blah. So dedicated Botox day. All your staff is doing that day is Botox. So they're cleaning scopes, they're getting people, you know, prepped, blah, blah, blah. Number one, that. Number two, we love them. We love these people. We love seeing them. We're so excited that they're here. We love Botox Day because we just listen to music and drink coffee and do Botox all day long. Like, it's very fun for everybody, and the staff can feel that in our mood. Number three, the lights go down. So we do ours in a surgery center, right? So the overhead fluorescent lights are off. We take the surgical lights and we basically shine them to the side of the room. So there's like light, it's not dark in there, but it's not on the patient. Like if you have to, because for people to know, your bladder has to be numbed for about 10 minutes just with lidocaine numbing jelly. So you kind of have to sit there. And if you're staring at fluorescent lights, it's awful. So we turn the lights off. So you're in a quiet room and we bring you a warm blanket. And it's amazing nobody fell asleep and fell off the bed. But like they're so relaxed. Instead of like, how long did you take? And blah, blah, and I'm cold and I'm staring at fluorescent lights. They're actually like, this is actually really peaceful and lovely. Right. And then I come in, if you're good at Botox, flexible scope. And I'm just chatting the whole time. Like, what are you doing this weekend? What dogs do you have again? Oh yeah. What's your great? And you get to know them because they're repeat people. Right. And they're like, okay, done. It's not painful. It's not stressful. And they come back because here's the thing. Botox works. It's the experience that sucks, and that's why they're not
Yep,
coming back.
we agree. And anecdotally, do you agree? Does it match up with this huge fear of retention when people Google it and they're like, I'm going to need a catheter after?
Yeah, at
'Cause,
the
yeah,
beginning of Botox, this is again years ago, there was a urologist who's like, I make all of my patients learn how to intermittent self-cath in case they go into retention after Botox. And I'm like, oh,
like,
good. That'll make you not interested in Botox.
yeah, that's my follow-up question. Like, how many actually showed up for their Botox
Yeah.
procedure when that was your protocol?
Well, and that's the other thing, they talk about, and like, how do we get people to come back and to trust this stuff, is it's how you talk to them. So if you say, yeah, the risk of this is that you won't be able to pee and you'll have to use catheters and that you'll get a urinary tract infection, that's not really explaining it in a way that feels safe and approachable. So I say, listen, the risk of this is not being able to empty your bladder as well. So I check your bladder now, and I check it 2 weeks after the Botox to make sure you don't have that. It's actually very rare. And a risk of this procedure is a urinary tract infection. So we give you an antibiotic beforehand to decrease that risk. Like, I can say that, like, that is my talk track. I will have that memorized till the end of my life. Because what I'm saying is there are risks, but we're on top of it.
Yep. Agreed.
Right. And it's much less scary.
And the other thing I like about Botox is like it's very easy to deliver the therapy versus some of our other treatments are more precise, whether it's needle placement in the leg, a lead perfectly aligned to the sacral nerve, right? I feel our quality of delivery is much more consistent with Botox. And I do think it's underutilized, poor talk tracks around it, poor experience for patients, and especially in these geriatric patients just soaking diapers that are not a good surgical candidate and have poor leg integrity. It is a very underutilized treatment.
Oh, I love Botox. If somebody was like, hey, Kelly, we'll fly you to Phoenix where you come down and you just do Botox for 3 days and we'll fly you back home, like, I could be a traveling Botox doctor. I love it.
Yep.
Shout out to manifesting that. Okay, so that's again, Botox is, and this is where people don't understand. Botox is for urge incontinence, overactive bladder, leak with urge.
Thank you. Yep.
Botox will not help with leaking with cough, sneeze, and laugh. We'll get to that, but Botox will not help with that. So, other third line, I'm going to call them third line therapies till the end of my career. Other advanced therapies are sacral neuromodulation. So it's basically stimulating the nerve to the bladder, and you can stimulate this via the sacral nerve in the kind of the upper buttock. That's the classic ones, been around for 20 years. There's 2 companies in that field now. And then you can stimulate it via the tibial nerve down by the ankle. Newer technology, but already multiple companies are coming out with that. Talk about those options.
Yeah, so moving on from Botox, sacral neuromodulation, it's definitely one of our more extreme options compared to medications, PT, Botox injection that lasts 6 months, a leg target, in my opinion. But when done by a very well-trained specialist that has done high volume, it can definitely be a very life-changing therapy option for patients with, I'd say, moderate to severe overactive bladder, urge incontinence, frequency. It can also help with fecal incontinence, fecal urgency, which affects 16% of women.
It's common.
And you want to talk about something that is not asked ever. I mean, only half of women will bring up urine leakage. Only half of healthcare professionals are screened for it. Oh, I mean, you think anyone's screening for fecal incontinence? I mean, I've had patients cry because that's my third question I ask. I ask about overactive bladder, then ask about stress incontinence, then ask about bowels, and then ask about GSM. I get to that one too. Yeah, I know. I got to throw that in for you. But bowels, I mean, you will have ladies take a pause, stare at you, and start crying because no one's ever asked them. And then they're like, oh my God, there are things that might help with this. Right. So sacral neuromodulation, just a broader indication for a bladder that's not behaving, bowels that aren't behaving. You did a great description. Yep, it is. It's literally like a pacemaker. And there's a testing period where you do a temporary test for patients, about 3, 5, 7 days. You take out these temporary fishing wires. People have different ways of delivering that. New technologies coming out surrounding that we're excited about coming down the pipes. And then 2 brands, which has been great. Competition always makes people behave better, be accountable. So it's been fantastic since 2019 to have competition in the space, to get better imaging modality clearance. We can now get full body MRIs, which is great for patients because there are a lot of patients that need an MRI below the neck. Better remotes that are more patient friendly, better patient management by reps, because it is a chronic therapy that needs to be monitored. You don't just put these things in and say bye-bye, see you later. To get the best results out of these more advanced therapy option, you need some hand holding. So it's been a really fun landscape the last 6 years to watch it greatly improve, just because there are two brands. So it's been a fun time. I think, Kelly, you can attest to that, to just have more choice for patients and see therapies improve.
Yep, totally. The biggest problem with sacral neuromodulation, in my opinion, is that it is not FDA approved for neurogenics. And we have multiple published papers to say it works great in multiple sclerosis, stroke people.
Yep.
I've had Parkinson's. Parkinson's is progressive, but it does work. It works in people with neurogenic diagnoses, but it is not FDA approved. So getting insurance to cover it is fraught. Medicare will do clawbacks. That is impossible. You do not want to deal with that. So I've been bugging the companies for every chance I get. I'm like, dude, you guys need a neurogenic indication. It's going to open it up to so many people that we know will benefit. It's a stupid line in the sand. But again, insurance and FDA, they practice medicine in this country. So I think that's my biggest problem with the technology. But nothing works better. Like Botox is great for most people. If you have somebody who's diapers a day, nothing will move the needle on the severity of overactive bladder urge like a sacral neuromodulation will, in my opinion.
I think Botox is pretty good for that too. I think they're both
sometimes you got to do both.
Sometimes you got to do both, right? Sometimes, we do combination therapy. Absolutely. I have patients who have had all these therapies, and we're also on a beta agonist. So that's the nice thing about our menu for overactive bladder. It's robust. So we have a lot of different targets with different mechanisms of action. So we can tailor therapies. And once again, when we started residency, Kelly, all we had were anticholinergics. I mean, can you believe that? That's all we had. And so to see this landscape just keep adding and moving along, I mean, that's awesome. And that's why I love what I do. That's where I get so excited when they come in and say, well, I leak. And then you get to present all of these things that we didn't have when we started trainings, and it's only getting better. So I feel very blessed to be in the space. Yep.
Yeah, totally.
We can talk about tibial target.
Okay.
So just like the sacral nerve goes to the bladder and bowels, and delivering energy to that makes this poor signal behave. It's restorative to this poor behavior, just like it is in the pain world. If you stimulate the nerve, and there are many ways to stimulate, whether it's implanting something directly, doing it through the skin, doing it with a small needle that is placed to the nerve. When we take that down to the leg, there's a tibial nerve that runs along the lower leg, and it's a highway into that same sacral nerve, up the spinal cord, to the brain, back down again. When we stimulate the tibial nerve with just a little needle, like acupuncture, but add electricity to it, we see frontal lobe changes on MRI that then have this positive effect. So it's going all the way up and back down to the bladder. And it comes from Chinese medicine, where we know that acupuncture can help dysfunctional nerve pathways. And so by what we call percutaneous tibial nerve stimulation, if we take a needle, put it in the tibial nerve, and then add energy and do weekly sessions for 30 minutes for roughly 12 weeks and then monthly, we can get a positive effect on the bladder. The challenge of PTNS, it's a lovely paradigm. There's a lot of barrier challenges, right? You have to have a team that can deliver the needle. You have to have rooms that can be tied up. You can't have insurance companies calling it investigational, even though it's FDA approved. You got to fail 2 meds a lot of times. Sometimes insurance only covers it for a year. And even though certain data suggests 78% were responders at 12 weeks with this very benign tibial stimulation, only 1 out of 4 typically make it to 12 weeks. And then that drop off at monthly is that much worse. Plus, monthly stimulation may not be enough to manage symptoms. I practiced in Central California for almost a decade. I had a wonderful setup for PTNS. I was like your Botox day. Like, I ran a PTNS clinic, and I was in the right market for it. I had a lot of older patients. I had a lot of very holistic hippie patients, right? They would rather come do PTNS than take a pill. I had a really great team that delivered the needle really nicely. Plus, we had an add-on placebo effect because they would do diaries. They would add in that behavioral management. What's your stress in your life? What are you eating right now in your diet? So we would definitely get like really good results in addition to behavioral changes that were chronic 12 weeks of counseling with my team, right? And we had great parking and we had great weather. Guess what? I moved to Denver. I live in Boulder, but like people are like, I'm not doing that. And I'm like, what do you mean? It's such a great option. So it's so funny, right? Like you have certain places that can support it, whether it's the insurance, the team, your business model. But I'm a huge believer in it because I saw really great results, and you never hurt anyone beyond wasting their time up, but they always read a book, right? So, and they love my team, right? So it's just a very positive experience, much like you talk about with Botox, where like, man, they made that experience like really great for me. It was like a spa. So then there's this concept of, okay, like in socialized countries, they don't have that level of help. They do just TENS units. So simple TENS unit, right? Like $40 off Amazon. So I'm actually like a big fan of that. But there's no financial incentive for providers to do that. There's the whole, like, they have to buy it off Amazon. They have to be compliant with it. So that can be challenging. I occasionally use them. And then since 2022, we've actually started to see approval of tibial implants, which is a pretty cool concept where you don't have to do surgery. It can be done with just local. There are quite a few different form factors surrounding that. I won't get into the weeds of that. I'm quite a nerd in that space. And we have more coming out. Right now, it's in a category 3 code. So sometimes that's tricky from a reimbursement perspective. So I think this space is very to be determined. But I think it's exciting because maybe we'll get more people treated. And it was added to the 2024 OAB guidelines as a therapy option. So, I just think it's going to take time. S&M's been around since 1997. We really didn't get cranking on it until we had a competitor in 2019. So people need to pace themselves. And one of the big device makers, actually 2, should be getting FDA approval sooner than later. And so once again, the more competition we have, the more offerings we have, the more we sort out the reimbursement, patient selection, how do we improve the efficacy? How do we improve the safety? Right. And one of my biggest things is just being accountable in the space, because I sure liked transvaginal mesh kits for the right patient when done the right way. And that was taken away from us. And that's kind of one of my biggest thought processes in this new space. How do we make sure we roll it out appropriately so that we can just keep giving patients more options with our menus?
Yeah. Well, I mean, I think it comes down to having urologists step it up. So many urologists don't want to deal with leaky ladies, right? And it's like, if the market is huge, which we know the market's huge, 80 million women over the age of 40, and urologists don't step it up for several reasons, it will go into less trained hands, meaning people who haven't had the years experience of dealing with the complications, right? Because, for the tibial is like, dude, the orthopods are in the ankle way more than the surgeons are or the urologists are. But they're like, but the orthos don't know how to deal with bladders, right? So it's like, at the end of the day, this is a bladder issue. They're much more comfortable putting urologists down in the tibia than having an orthopod do it and do bladder follow-up. So it's really like, if urologists don't take this domain, it will go to other people, because women need help.
Kelly, let me poll you here. what do you feel about pain doctors doing S&M?
What do you? Yeah, don't get me like. It's like the cosmetic people puffing up effing clitorises.
Or
It's
ENT doctors having an M-Cella chair for all of their patients?
yeah. So it's like, but I mean, it's gonna happen more and more and more. Of like the true expertise person. There's not enough of them, and we're not managing them efficiently to make them. You know how much more efficient I could have been had I had like unlimited support and resources, right? But it's like you got to have the people who are the biggest experts staying in the space because the demand's so big. People don't know. People don't know that the ENTs don't know a darn thing about the bladder. You know, they just want help.
Yeah.
So it's
they just know how to bill for that chair.
yeah.
Well, I think this is a great pivot because I think we have a recent success story when we talk about the adoption of Bulkamid for stress incontinence. I think we've won in treating more women. And how did we get there? I think we're making progress after the mesh sling debacle.
Yeah, I mean, I'm holding breath. First of all, Bulkamid's amazing. Basically, I say it's filler for your face, put down there by your urethra, because people know what filler is. Although
with
people
a medical code.
with a medical code that insurance covers for, but people think that filler is Botox, and then they get confused that Bulkamid's Botox, and they're very separate things. Bulkamid adds volume to the urethra, it's a revolutionary product, which is way better than any other bulking agent. I went in super skeptical because I'm good at slings. I have happy women with slings, and I love Bulkamid. It's easy. There's no downtime. My biggest worry about Bulkamid is declining reimbursement. The product price is going up, the reimbursement's going down, and pretty soon no urologist will be able to offer Bulkamid because you actually have to pay money to treat patients with Bulkamid. It's a big problem.
Agreed. And also, for it to make sense from a healthcare economic standpoint, it should be done in the office.
Can't
we can't even do it.
Reimbursement, right? You can't.
So it breaks the system that much more. Love the product. Yes, they need to make the reimbursement more favorable. But yeah, it's just been, once again, talking about markets in California, it was very challenging for me to offer mesh slings to women. They just were terrified. And I'm the first one to say slings work great, well trained in them, think they're a great option.
Yep.
But in 2025, the amount of fear factor in patients and anxiety and Googling, I mean, thank God there's Bulkamid, because
thank God.
It's hard for me to even sometimes get through that offering with patients with a minimal risk of UTI, bleeding, having to repeat it, risk of sedative. I mean, in 2025, even that talk track can be challenging with a certain patient. I can't even imagine a mesh sling anymore, right? Like I just have to pass that off to other people where they can take that on. But in my community practice, if you failed PT, and I always say, we just need to cheat a little bit. Sometimes it's okay to cheat, right?
Yeah, it's like
GLP-1, whatever it is. Let's cheat a little bit and do a little filler in your urethra.
Yeah,
and
I love it. Yeah. And people, I mean, women only had physical therapy and mesh slings. Unless you were going to do the very invasive autologous rectus fascial sling, which is incredibly invasive and not recommended as first-line therapy. But it is in the stress incontinence like guidelines as an option. But I'm like, it's way too invasive for first-line therapy. But so it was physical therapy or slings, and that's it.
You need an in-between.
Yeah, we needed an in-between, and the Bulkamid is the in-between. I also think that everybody with mesh in their pelvis, sling or prolapse, needs to be on vaginal estrogen for life. We have to care about the tissue. I think that's the big thing, just going back to the whole pelvic floor mesh thing for a hot second. How many of those people were put and kept on vaginal estrogen and
Not
just
enough.
had thinning and erosion of mesh over time because of atrophy, right? It was never talked about. So it's like, you got to keep, my belief, if you ever have mesh in your pelvis, you have to stay on vaginal estrogen for life. But I mean, I think everybody should be on vaginal estrogen for life, so it's not that big of an ask.
We all need chapstick for our lips while we're
sunscreen?
not using, exactly.
Right. Yeah, you don't stop sunscreen after age 65. You don't stop flossing.
So it's all care, self-care.
Yeah.
Yeah.
Anything else you want to say about slings or Bulkamid?
No, I mean, but once again, I'm very optimistic knowing that when we started training, we didn't have Bulkamid. We had bulking agents that didn't work as well.
Mhm.
So outside the reimbursement piece, which is a burn, I think it's a really exciting time for female people practicing female urology, whatever you want to call it, urogynecology, avoiding dysfunction. We have a lot of growth in the space, I think. But yes, reimbursement needs to be sorted out. I think for patients that are bothered by this, finding the right person is the first step.
Great question. So, what's the
I mean,
difference? What now? They've changed the definition, so it's even harder now. What's the difference between a urologist, a female urologist, and a urogynecologist? And how would you? Because people are like, "Who do I see?" And it's like, well, you see the one who actually likes doing bladder leakage work.
exactly. Because it's not just the definition. Right. There are people that are great at voiding dysfunction leakage with all those different terms in their fancy name. I'm just a female urologist who did a fellowship, and I love treating voiding dysfunction, leakage, things like that. I don't really love doing prolapse anymore. I used to do it. Kind of went by the wayside with vaginal mesh being taken away, and I had a lot of old patients where I just didn't think a robotic sacrocolpopexy was appropriate, and pessaries are limited for many patients. Yeah. So, in finding the right person, like your primary care doctor may not know where to send you. And so, I recommend, honestly, most patients that find me, they just Google and do their own research of choices in the marketplace and are just like, yeah, you seem to kind of know about this stuff. And there's a lot of stuff I've never heard
Right.
of.
And you seem to care about it.
And I care about it. So, hopefully, there's someone somewhat near you, but I also throw out their telemedicine. I've actually treated patients start to finish with an S&M implant and only touch them for the P&E temporary wire test and placing the implant and then all the follow-up through telemedicine. So let's pray they don't get rid of telemedicine in September. It's always tenuous.
But my personal opinion right now, it wouldn't surprise me if they did. Like I don't think telemedicine is secure at all right now, and I don't think people realize that.
And it's so challenging because access to people like us is so limited, and patients they have low motivation or hope about getting this improved, and telemedicine is such a good first step.
Yeah, I totally agree. But yeah, I mean, I think to me, I'm like, dude, if Medicare is looking to cost cut, and they're like, dude, doctors are going to probably do telemedicine whether they get paid for it or not. Let's just cut reimbursement. It wouldn't surprise me. I don't think we have protection for telemedicine going forward after the end of this year.
They pushed it back twice now, so
now we have a new administration.
All we can do is hope they keep pushing it.
Yeah, but so I don't think I don't think people know that it's under threat, and so therefore people can't advocate for it because they don't know it's under threat.
Fair. When I schedule patients out, I'm literally like, just so you know, you want to do telemedicine in October, but we may need to change it to in-person if telemedicine is no longer an option.
That's so forward thinking of you. Let's talk about two things. Let's talk about the chair. I think I can say the brand name because there is only one chair to my knowledge. It's the Emsella chair. I don't think there's more than one chair. And then the at-home pelvic floor apps where you put something in your vagina and you squeeze. There's a bunch of different brand names for that. People always ask me what I think about it. I think for the at-home apps, they're cheap, they're easy, they do have proof that they work, but it's really your motivation that you're going to do this on the regular. And I think that's where you see a big drop off. Like you get sold these sexy things and then you're like, well, it actually takes time and something in my vagina and I have to pull up an app. So I don't think long-term implementation is great with them. And then for the Emsella chair, if it works, it's very expensive and it must be repeated. And that's where I think the cost does not outweigh. And people aren't told you're going to have to keep doing this to keep it working. So do you have a more favorable opinion about any of that?
So the cheap at-home options, I especially think it's very reasonable if you don't have access to a pelvic floor PT. You're motivated to do it. Historically, when patients come in and they've done those apps, I haven't gotten the best reviews of it in regards to success,
Yeah.
adherence.
We see all the failures though. That's the thing.
I see all the failures, but I'm not overly opposed when it's not a huge wallet biopsy. The chair I have issues with because it's not part of our guidelines. Okay, so when patients ask me about it, I say, look, I'm
And
here
the
to offer
guidelines were just
things.
updated.
Yeah, and I'm here to offer things that are based on society guidelines. I try and practice within what is recommended by our thought leaders. And I have a problem with it being a massive wallet biopsy. And then I asked who recommended it. And once again, when it's like a ENT doctor, I'm like, I'm kind of confused by that, right? Like that doesn't really line up for me. It'd be one thing if I offered it, right? But and once again, it's kind of a glorified TENS chair. Well, why don't we go back to buying that $40 TENS unit off of Amazon for 40 bucks?
Yeah. Yeah. They're incredibly expensive
Yeah.
to buy. And so you're pushed to sell them to make your money back off of them. And they're very expensive to the patients. And then patients, it'll work or it won't work either way. It does work in some people. Like otherwise they wouldn't exist. But you have to keep doing it because your muscles will then, the effect wears off.
And I don't know how many patients are willing to pay for it when, I don't know about you, but my patients are like, what do you mean I have a $30 copay? Like, what do you mean my Gemtessa is going to be 40 bucks a month? And I'm like, that's with the manufacturer coupon plus your coverage with insurance. Like, I can't get it cheaper.
Yeah.
Quick plug. Thank you, Mark Cuban. GoodRx does have a Gemtessa assistance program if you're very low income. And I have gotten a couple patients Gemtessa for free where they, Medicare was not going to happen. Manufacturer coupon too expensive. So just once again, just awareness. There is a assistance program. You do have to be very low income and you have to provide the paperwork for it. But I have had success with that. But I just want people to know that like these things are out there because all I hear is, how do you prescribe Gemtessa? Like, how do you do it? And I'm like, there's so many ways to do it. You just have to be dedicated to like, how do you jump through those hoops of fire? And people will be like, well, I just don't want to do that. Well, I'll say this. All my patients on Gemtessa, estrogen cream, guess what? They're all chronic patients to me. I get them chronically.
Right.
Versus one visit of discouragement.
And they're happy with you and they send you your friends. They're friends.
Yeah.
Where can people find you?
I have a little clinic called Bladder Boutique. I'm part of
Is it the Bladder Boutique or Bladder Boutique?
Is it the Facebook or Facebook?
Ha ha ha. Got it. Bladder Boutique.
Bladder Boutique. And yeah, it's kind of a ridiculous name, but the feedback from women, they come in giggling and they're like, I literally came because this name was so funny. So
I love that. Dude, how are you brave enough to like name it that? Or was it like a no-brainer?
How are you brave enough to open the Casperson clinic and pivot to podcasting?
I love female urologists. Female urologists are the best people ever.
I think it takes a little bit of crazy, Kelly, and a little bit of confidence that you have a product that's desired.
Yeah.
And you're willing to build and have a little bit of faith.
Yeah. Well, and for what it's worth, I think female urologists are incredibly badass. They're unapologetically themselves. They know their shit. Like
unfiltered.
Also unfiltered. slightly swear word leaning.
I don't think we dropped a cuss word today.
Good job.
We did so good.
I get to take the I get to click the non-explicit button on this podcast episode.
I'm shocked. I'm actually shocked by that.
I know, it's good for us. So don't limit your exercise because you're leaking. Don't think there aren't options. You do have to go to somebody who cares, who likes doing this. Don't go to somebody who doesn't do a lot. That's my best advice. Go to somebody who's like does tons of it.
High volume
everything. Because they're gonna they know the proof's in the pudding. They know that people get better. That's why they like doing it, because they love seeing those wins and they get them a lot. And you want to be part of that team.
Well, you love treating leakage because the bar is set so low, right? They don't even know what it is, what these therapies are, that they actually all have. They're perfectly imperfect, but they all have like some good efficacy. risk profiles for many of them are reasonable. So like we're kind of set up to win with these patients if we're
Yeah.
dedicated to what we're doing.
And quality of life, fixing quality of
Right.
life is awesome. So one of the top two that come to my mind, I did a sacral neuromodulation on a woman. She was housebound, would not leave because her bladder leakage was so bad, and she got to leave her house then, which is like, those are massive wins. And then my second one that comes to mind is a younger woman, perimenopause, did a bulkamid for stress incontinence. She brought me a plant on the thank you post-op visit, and she's like, I'm not wearing any underwear right now because I'm not going to leak. And I was it totally cracked me up. Like, she was so stoked about it, about not having to even wear underwear. Do you have any big wins that come to your mind?
Oh, all the time, especially with like the spinal cord injury patients who are just so humble, and it's so meaningful to take care of those patients. But I had a young, recently 30-year-old gal. She had cauda equina, horrible fecal incontinence, urinary retention. And when we did after we did her implant, she came back and she's like, oh my God, I went on a date. And this is someone who hadn't had a life for a year, with their
Oh my God.
with their injury. It's like, that's like life changing. Can we do one more quick plug?
Yeah.
Ambulatory urodynamics. Are you excited about that?
I'm excited about that.
Okay, sorry. We don't have to deep dive in that hole. That was one I wanted to bring up today. And
I didn't do a lot of urodynamics because like once you know bladder leakage enough, I don't need a test to prove what I've already heard in your story.
Agreed.
But urodynamics is useful for the people who are like, I just don't know why I leak, or like they've got a elevated post-void residual and you got to figure out retention. So not your bread and butter people.
Correct.
But they're developing urodynamics that you can do at home now.
Mm-hmm. And that triggered me because the CEO of that is we're podcasting before Memorial Day weekend. He was actually a Naval Academy graduate. I had the pleasure of meeting him a couple years ago, and he's very entrepreneurial. And he's like, I'm going to do ambulatory urodynamics, and then it got FDA approved a couple months ago.
I did not know that.
Yeah, so he should be on your podcast. Thanks, Derek. And he was a Marine, and he was shot in Afghanistan, paraplegic. And so he personally went through all the cathing and the urodynamics and the Botox, and just, God, this is terrible. This is so horrible. And how can I come up with solutions for this? And he's gone through a couple iterations, but his urodynamic system actually got approved recently. And I'm really excited to use it in the right patient. And once again, giving dignity back, because urodynamics, I mean, that has to be the most ridiculous. Well, once again, it has not evolved in so long. And
I ask people,
I'm heavy lift, right?
Yeah, I'm like, have you had urodynamics? And they're like, I don't know. And I'm like, that means you haven't had urodynamics because when you've had a catheter in your anus and a catheter in your bladder, and then people stare at you and tell you to urinate.
Yeah, so I'm the same way. In opening my practice here in the North Denver area, I wasn't going to purchase a urodynamics machine. I'm waiting on this ambulatory urodynamics because, once again, why are we doing the urodynamics? Are we doing it to change our treatment algorithm, or are we just testing to pay off that machine? And I hope it's we're doing it to actually change our thought process on how to treat a patient, or make sure their upper tracts are safe with high pressure and things like that. So very excited to play with that. Love playing with all these new things coming out in the space.
I love it. Well, just to hit back on insurance again, our insurance where we are for bulkamid, because these are old bulkamid code and approvals. This is old code and approvals. So they said you needed to either leak in the clinic or you needed a leak point pressure less than 100. And I'm like, you can only get a leak point pressure less than 100 on urodynamics. And to take a healthy, fit female with mild stress incontinence and put a catheter in her behind in her bladder to get insurance to approve something pissed me off.
Yeah, so I've had a couple peer-to-peers with 80-year-old pulmonologists for Medicaid patients to get their bulkamid approved, and they're like, well, you haven't done urodynamics. And I was like, well, you can come and be abusive to a patient to do that unnecessary testing versus, ma'am, why don't you just cough in front of me with a small drape of modesty, and I see that leakage and we're good to go. And they're like, okay, approved.
I know.
So when we first
The
started, it
guidelines
was
need to change.
really, really painful. I will say the stress urinary incontinence guidelines did get updated, and they have scaled back with like amount of testing that needs to be done. Once again, it's much more like, surprise, surprise, erectile dysfunction, where a guy walks in with erectile dysfunction, and the guidelines have always been like, you can get whatever you want.
Yeah.
Get
We're
an
not like
IPV more.
prove that you can't get an erection before you get treatment. Said nobody ever.
Right. And
It's
so,
very
you know,
nice, very nicely pointed out by us. Thank you, Dr. Rogers.
we need that philosophy for leakage because the adherence is so bad. How can we get these patients to better as fast as possible?
I love
Right.
that.
And safely, right? And
No,
not,
yeah, it
not
was like-
skipping corners, but once again, for me, my typical workup is urinalysis, PVR, leak test.
I love it. I love it. Thank you for your time and your brain. And everybody check out Bladder Boutique, North Denver.
Yeah.
Bladder
Have
Boutique.
fun there.
Bladderboutique.com. What is it?
Bladderboutique.com. And I'm not a big social media person. My website
Which is
really
shocking because you do have a good
patient education.
You do have the humor for it.
I do, but I save that for you know, my dance classes, and I'm really active
Your
and
kids.
my sidelines with my kids. Like that's where I like channel that energy.
Yeah.
I don't know how. I mean, praise you and Rachel Rubin and Rena. You guys are killing it with all this social media stuff.
Thank you.
And I'm so glad you guys channeling your energy in that way is so meaningful for you, and you're helping so many patients and people out there with raising awareness for these like issues that need to be talked about. So
Totally.
thank you for doing it so I can go run up a mountain. I really appreciate that.
You're very welcome. October 5th, I'm going to be in Denver doing a keynote at an event called Thrive. Follow my social media to find out more about that. But hopefully I get to hang out with my friend Alex Rogers when I'm in Denver too.
We'll be moving. Yep.
Perfect. Thanks for coming on.
We'll be involved.
Yeah. She's either gonna kill me spinning or kill me hiking, and I'm here for it all.
Or we'll go dance. Might just.
Or we'll go dance. Ooh. All right. Talk to you soon. Love you.
Bye, guys.
Bye.